The Black Women's Learning Institute is a national center focused on the health and wellness needs of Black women across the lifespan. I'm Lisa Frederick.
And I'm Hannah Tasama.
This is our story.
We've been colleagues and friends for 20 years, and we co-founded BWLI in 2020. We are champions for health literacy, having led HIV education programs throughout the U.S., focusing on the South. Our commitment to HIV and aging has taken us to the White House, across the U.S., South Africa, Australia, Mexico, and Austria.
The Black Women's Learning Institute was born out of the times we lived in. In 2020, we witnessed the murders of George Floyd and Breonna Taylor at the hands of police. We saw undeniable systemic racism exposed by the COVID-19 pandemic. In the midst of this fear, uncertainty, and injustice, we felt the need to hold a series of roundtables on Black women's health and wellness.
In BWLI's first year, we held listening sessions in Baton Rouge and Louisville. We also conducted a national survey on Black women's health and wellness, which included responses from over 900 Black women throughout the U.S. We worked very closely with the late Dr. Stephen Karpiak, one of the principal investigators for the groundbreaking research on older adults with HIV study, and this was the true impetus to our work in translational research. In our survey, the majority of women were from southern states. 84% represented Texas, Georgia, North Carolina, Tennessee, Louisiana, Kentucky, Arkansas, Alabama, South Carolina, Florida, and Mississippi. When we asked about their top barriers to healthcare, 40% said finding a doctor I like, and 29% said finding a Black doctor. When we asked Black women whether they believe their healthcare providers listened to their concerns, a third said no, or that they were unsure. Nearly half reported that they always, usually, or sometimes experience discrimination from their healthcare providers. The findings from our 2021 Engage, Empower, Educate survey led to the development of My Prevention Green Book in collaboration with the University of Louisville's 550 Clinic, and to the creation of our white paper on anti-racist clinical care.
The stories from our listening sessions, the data from our Engage, Empower, Educate survey, and the overwhelming disproportionate burden of disease and discrimination Black women face prompted the next phase of our work. Black women attempt to thrive with intersecting identities while navigating a healthcare system that is systemically racist, sexist, and transphobic. We are not seen, heard, or treated in a way that recognizes and respects the complexity of our lived experience. Our white paper tells a compelling story rooted in facts and research to persuade healthcare providers across the country to implement an anti-racist clinical care approach. We began the white paper with an excerpt from the Combahee River Collective, a Black feminist organization formed in 1974 in South Carolina that was actively committed to fighting racial, sexual, heterosexual, and class oppression. They stated a fundamental truth: Black women are inherently valuable. The need to even say this exposes the history of the racial and sexual oppression of Black women. We lay bare 400 years of abuse and indifference, including the eugenics movement, which attempted to selectively breed out undesirable characteristics from the U.S. population over the course of 150 years. Eugenics was widely supported by white scientists who wrongly saw it as a positive way to improve the population. In truth, it only increased the racism inherent in our healthcare system.
For example, in 1973, the case of 12-year-old Minnie Lee Ralph and her 14-year-old sister, Mary Alice Ralph, in Montgomery, Alabama, garnered much media attention. At that time, Alabama permitted parental approval of sterilization for the mentally incompetent. The sisters were declared mentally disabled, and their mother was given paperwork from the local family planning clinic that she thought was for birth control shots for them. She was illiterate, but trusted her providers and signed the forms with an X, unknowingly authorizing their sterilization.
A lawsuit filed on their behalf revealed that more than 100,000 mostly Black, Latina, and Indigenous women were sterilized under U.S. government programs for decades. We could list many other historical examples, but the truth is that institutionalized racism remains embedded in our healthcare institutions to this day, resulting in hidden biases and health disparities. For example, certain widely followed clinical recommendations regarding patient care were written using a patient's race to influence how they should be treated.
Sometimes there are clear biological differences by race. For example, there are genetic differences that contribute to a higher prevalence and more severe manifestations of lupus among Black communities. Genetic variations are also responsible for racial disparities related to sickle cell disease. So race-based clinical algorithms are not always inherently flawed, but each one needs to be carefully and systematically reviewed before implemented. Not doing so can significantly increase errors in both diagnosis and treatment.
Some clinical recommendations are made based on actual biological differences, while others are based on systemic racism. Let's consider eGFR, a measure used by clinicians to calculate kidney function. For many years, it gave separate results for Blacks compared to other races. But in 2021, a key task force on kidney care released new recommendations eliminating race as part of eGFR because it was overestimating kidney health in Black communities, leading to delayed treatment. In our white paper, the stories of Black women are amplified to highlight current examples of racism in healthcare, including the story of Dr. Angela Anderson, a Black clinical psychologist. She complained of chest pain and shortness of breath to a white doctor who dismissed this as postnasal drip and suggested she simply blow her nose. When a pulse oximeter found her oxygen levels to be low, the doctor said that sometimes they don't work on colored fingers. She advocated for herself and went to an ER where she had a CT scan, blood tests, an echocardiogram which revealed a pulmonary embolism, pneumonia, and an infarction in the right lung. She spent 4 days in the hospital on IV antibiotics and blood thinner. Some key concepts in our white paper grew out of our work with our partner, the Denver Prevention Training Center, or Denver PTC. Lisa Frederick developed the intersectionality module and co-facilitated these trainings virtually.
Here from the Denver PTC is Associate Director Ty Edward Few to discuss their work on racial health equity.
As a result of the impact of racism on the health outcomes of Black, Indigenous, and people of color, or BIPOC, the Denver Prevention Training Center developed a suite of courses for medical providers on health and racial equity. The main course, the Introduction of Anti-Racist Clinical Care, or IARC, is designed to increase providers' awareness of the impact of medical mistrust and how implicit bias can negatively affect patient-provider outcomes. Additionally, IARC helps providers learn how to incorporate intersectionality into patient care. IARC is meant for people who have a basic understanding of systematic racism and how it relates to health inequities. And if you as a provider have wondered how to move from awareness to action regarding racial and health inequities, IARC is for you. IARC's primary goal is to increase culturally responsive, high-quality care for people living with HIV, to maximize the quality of care and improve engagement of patients from diverse backgrounds. IARC is a 6.5-hour didactic, interactive training that is available either online or in person, where providers have the opportunity to reflect, practice skills, learn strategies, and tools to improve patient interactions and build a more inclusive clinical practice and programs.
The goal of anti-racism is to dismantle structural and institutional racism and actively change the policies, practices, behaviors, and beliefs that perpetrate racist ideas and actions. Providers must approach anti-racist clinical care with intention and action.
To achieve health and racial equity, we must employ a whole of society approach particularly including public health systems, to instill trust in our communities and provide the highest quality care for everyone. It is our commitment to work toward improved health outcomes for Black women, and we welcome the opportunity to work with you toward that end.